Thank you for the opportunity to contribute to this educational activity with my two colleagues. So first of all, I'd like to set the scene about this factor VIII mimetics, and so that you fully understand what their role is for the treatment of hemophilia. You all know what hemophilia is. Congenital hemophilia is characterized by an factor VIII deficiency of variable severity, and as you all know, patients with severe moderate disease will present with spontaneous bleeding complications that mainly affect the musculoskeletal system. So although this is an hematological disease, the main complication deal with the musculoskeletal system, although these patients can also present with intracranial bleed or other bleeds. As you can see on this slide, there is a good correlation between the levels of the clotting factor that are measured in the blood and the bleeding phenotype. So as you can see on this slide, patients who do not produce factor VIII can bleed frequently, up to once a week, 52 bleeding episodes per year in the absence of treatment. But as you can see, once there is a little production of factor VIII in the blood, the bleeding phenotype is totally different. And that has provided the rationale for trying to convert the patient from severe into moderate. We also know that there are some patients with moderate and even mild hemophilia who do present with a so-called severe bleeding phenotype. So this is the coagulation cascade that initiated by tissue factor 7A that leads to the degeneration of thrombin. But as you can see on the slide, there is an amplification loop, and this amplification loop is critical. And as you can see, factor VIII plays a very important role here. So you can easily understand that if factor VIII or cofactor VIII is missing, well, clearly this amplification loop does not work properly and the patients will not generate enough thrombin. So you might ask the questions, why do our patients with hemophilia do bleed in their musculoskeletal system? The most likely explanation is that tissue factor is present in low concentration in these tissues, so that patients with hemophilia, well, since this amplification loop does not work efficiently in this musculoskeletal tissue because tissue factor is not there, well, they bleed in this specific tissue. So that's one of the most likely explanations. Well, clearly hemophilia is a bleeding disease. Patients do bleed in their joints, in their muscles. They can present with life-threatening bleeds. They develop pain. And as you know, that will result in major functional impairment, but hemophilia is much more than that. Hemophilia is much more than exclusively a bleeding disease. This disease and its treatment will impact on your daily life, school attendance, productivity at work, career, your psychosocial environment, your mental health, and for the entire family, the burden is huge. So what are the current goals of hemophilia therapy? Certainly to prevent the bleeds, to treat the bleeds, to prevent joint damage and arthropathy as early as possible in life, to address the complications and the comorbidities of the past, and certainly to improve the quality of life so that patients with hemophilia can live more or less a normal life. So as you know, the classical treatment has been replacement therapy substitution by factor VIII concentrate purified from plasma and then produced by biotechnology with major safety issue in the past that you all know. But there are other challenges of this treatment that are illustrated on this slide. And Carmen, you will come back to that when reviewing with you what are the clear advantages of factor VIII mimetics. Well, the first major challenge is the IV administration. Well, clearly, need for venous access is there, and there is a major treatment burden with this, and not every patient can adhere to this. And venous access can be highly problematic in young children, in older patients. The second limitation is the rapid elimination. So it has been successful over the last decade to improve the permanence of factor VIII in the blood, but still, many patients need to be treated at least once a week with the most recent version. Huge treatment burden, and also there is a fluctuant effect that also impacts on the patient's life. And the third major limitation is certainly for factor VIII immunogenicity, resulting in a significant proportion of the patients in the development of alloantibodies that inhibit factor VIII that you give to this patient. So treatment failure, but also the need to use bypassing agents, and ideally to eradicate this inhibitor. And we will see together how mimetics, factor VIII mimetics, can help our patients with inhibitors. And clearly, there are unmet needs for patients in hemophilia. They are listed in blue with the expectations for the future, what we should try to offer to our patient. We should try to avoid the development of joint damage. We need to prevent pain. We need to manage pain. Ideally, our patients should have zero bleed, including zero subclinical bleeds, the small bleeds that we do not easily detect. We need good therapies for our patients who unfortunately develop inhibitors in the past that could never be eradicated. And certainly, we need to improve the psychosocial health of our patients, help them to achieve a normal life. We know how difficult it can be to implement prophylaxis in my center. Until this mimetics became available, I was never able to achieve 100% prophylaxis in my patient, although this is what the guidelines tell us to do. But no, 100% of my patients are on prophy because the treatment do allow this. And certainly, we need to make sure that we also provide good treatment options to patients who do not have severe hemophilia, moderate, mild hemophilia. And also, we should try to do this globally because, as you know, 75% of our patients globally do not have access to treatment. And clearly, the mimetics here, and Cihan, you will address this, how the new treatments can help us achieve this very ambitious goal. So let's now move in the new treatment landscape of hemophilia, because there is a lot to say, Carmen.
Yes, there is really a lot to say. And I think the very recent developments and the future developments in this treatment landscape, they can really realize those expectations that you, Cedric, just mentioned. So looking at the current treatment landscape of hemophilia, we can say that we have, in general, two different groups. So we have the traditional replacement therapy, where we administer the patients factor VIII or factor IX traditionally intravenously. I mentioned two groups. Why? Because I think gene therapy is also a sort of replacement therapy, but in this case, patients endogenously produce either factor VIII or factor IX after receiving this single IV infusion. And now coming to the so-called non-replacement therapies, the bispecific antibodies and the rebalancing therapies, which are typically administered subcutaneously. And here you can see the multiple treatment strategies a little bit more in detail. You see that we have plenty of standard half-life factor VIII and factor IX products. Then let's say the extended half-life products, which in average led to a prolongation of 1.5 for factor VIII and to a substantial prolongation in factor IX, where patients can use this product once weekly. This is also true for the ultra half-life prolongation product, FNS Octococ Alpha, which is now available, providing high factor VIII levels and which is traditionally used once weekly. Gene therapy has been licensed for both hemophilia A and hemophilia B, but let's focus on the non-factor therapies. We have the rebalancing therapies. Concizumab, marstacimab have recently been licensed for inhibitor, respectively non-inhibitor patients. They are anti-TFPI antibodies. And then we have fitusiran, which is very close to licensure, a small interfering rRNA antithrombin, which can be used in hemophilia A and B as well. And you just saw this slide from Cedric, and the properties, and particularly for the clinical implication of this treatment, shows you that factor VIIIa mimetics typically are administered subcutaneously. They have long half-lives, providing an infrequent, rare or seldom administration. And very importantly, they are not affected by factor VIII antibodies, and they themselves have very limited immunogenicity. So they are not a factor VIII. They do not have a full cofactor activity. They have a partial cofactor activity, and their task is to bridge factor IXa with factor X in order to generate factor Xa and afterwards thrombin. We have both approved and investigational factor products here in this field. So emicizumab, which has been approved in 2017 for adults and pediatric patients of all ages, and which is indicated for routine prophylaxis to prevent or to reduce the frequency of bleeding episodes in people with hemophilia A with and without inhibitors. And this is once more a typical characteristic. All those factor VIII mimetics are designed for prophylactic treatment. And then we have the MIME8, the NXT007, and INNO8, 3 products which are still under clinical development. So, looking at the mechanism of action of factor VIII and the bispecific antibody, we know that factor VIII is administered intravenously. The particularly plasma-derived, but also recombinant product has a short half-life. It is neutralized by antibodies and protected by endogenous von Willebrand factor. However, the emicizumab is subcutaneously administered, has a long half-life, is not affected by the inhibitor, and is completely independent of von Willebrand factor. The most striking differences is that natural factor VIII has a full cofactor activity. It promotes phospholipid binding, stabilizes factor IXa active site, and bridges factor IXa to 10. And this is particularly the partial cofactor activity, what emicizumab has. Its task is to bridge factor IXa to factor 10 and to generate thrombin. This is achieved with a dosing strategy, including a loading dose of 3 milligram per kilogram body weights given at weekly intervals for 4 weeks, and then followed by a maintenance dose, which can be given weekly, biweekly, or monthly. Now coming to the next generation factor VIIIa mimetics, and they are no bioequivalents, they are different. So MIME8, which is an IgG4 as well, has a monovalent anti-factor IXa arm that targets the factor VIIIa binding helix, enhancing the factor IXa proteolytic activity and the factor X activation. And the rate of factor X activation is 31-fold compared to emicizumab. The dosing strategy is adapted according to weight groups. It's not adapted according to the precise weight in kilogram. And it is administered subcutaneously using an injection pen. Now coming to NXT007, here we also have a bispecific antibody, but structural changes have been made. Particularly, you can see this in the light change of these molecules. Here, mutations were introduced to each chain to enhance the cofactor activity and to generate more thrombin. The dosing strategy has to be defined. Optimal dose is still being determined, and this product is also given subcutaneously. Now coming to a total different molecule, which is INNO8. I told you that factor VIIIa mimetics are typically delivered subcutaneously, but this is not a bispecific antibody anymore. This is a bidomain nanobody, which is about 5-fold smaller than the IgG antibodies and which is delivered orally. So typical attributes of this molecule is the so-called protection technology, where serum albumin is bound to conjugated fatty acids with the aim to prolong half-life. And this really succeeded, at least in beagle dogs, as shown here, 115 hours. And in total, we can say that this is really a very new factor VIII mimetic, combining 3 cutting-edge technologies, nanobodies binding to factor 9 and 10, therefore bridging both factors and generating thrombin. The long half-life achieved with the protection technology, and the oral absorption with the so-called snack absorption enhancer. This snack absorption enhancer takes care that the molecule will be absorbed in the stomach already, and it's not something very new. It has already been introduced with semaglutide. So with that, I set the scene. I introduced the current and new products, and Cihan, you are going to take care for patient considerations and eligibility.
Absolutely, Carmen. Thank you so much for really giving this overview on the evolving treatment landscape with these new therapies, and also describing the new factor VIII mimetics and their properties. But the question now is, how are we going to use these new treatments in clinical practice? So what are the patient considerations? Who is eligible? And these questions are true for the first generation of factor VIII mimetic that is now in clinical use, but also true for the evolving or emerging factor VIII mimetics. And I think we all agree that proper patient selection is important. I think it starts with the discussion with the patient to talk about the goals, to define the goals of the treatment, but also you as a treater should know your goals here. And careful patient assessment is important, because you have to think who is going to benefit from this factor VIII mimetic therapies. Usually patients with severe hemophilia A, but also those with moderate hemophilia A with a severe bleeding phenotype, with or without inhibitors, are potentially eligible here. But with the first generation of factor VIII mimetics, so they can also be used in infants and pediatric patients. So and we see here really a quick uptake, at least in the region where I have an overview here. And I think one important consideration is that factor mimetics are not a monotherapy. So they are used for prophylaxis, but they might be combined with other therapies and to maintain appropriate hemostasis, especially in certain settings when people develop breakthrough bleeds or in the setting of surgery. And in more detail, let's look at some of the considerations when we transition patient from a previous therapy to mimetic therapies. So the patient selection includes like information on inhibitor status, and as the population of people with hemophilia ages, so age, but also it's important to understand comorbidities as the population ages. And as we have a discussion around like specific safety aspects here, treatment history is important. And what I really would like to emphasize is patient education. This is something where I took a lot of time to explain mechanisms of the new treatment, to talk about like the route of administration, and also to talk about the expectation of patients here. So this is prophylaxis, and they might combine. And then you should have also a transition plan here. And the question is, do you need a washout period after a previous, or could you immediately overlap here to discussion around dosing, monitoring. Also discussion about safety issues become more and more relevant, like talking about thrombotic risk, potential drug interactions. What is becoming complex is lab monitoring. So you should know that there is interference with the routine coagulation tests that you use. And you should also have an emergency plan in case of bleeding or in case of other acute issues here. And sometimes patients, of course, need also psychosocial support here. Factor VIII mimetics are not a one-size-fits-all therapy. So they offer some degree of personalized prophylaxis. So they are administered subcutaneously, weekly, bi-weekly, or monthly instead of intravenous infusions. And we have heard the latest development is even developed for oral administration. So, and there is personalized dosing based on weight and not on trough levels that were used in the past with factor levels. And of course, there is the situation here where you need on-demand factor therapies or bypassing agents. And as I said, laboratory monitoring is something that becomes really complex here. So APTT will artificially shorten, but this will not reflect the hemostatic capacity or the clinical effect of this therapy here. So it cannot really be used anymore, but also in addition to the one-stage clotting assays, also chromogenic assays are not really reliable, especially if you use human reagents. So if you want to measure endogenous factor activity or the factor that you replace here, then chromogenic assays with bovine reagents are the preferred assays for measuring factor VIII activity. And likewise, inhibitor testing with the Bethesda assay will be affected when patients are on these treatments here. There is a lot of discussion about like thrombotic risk, but they're in clinical routine, so the thrombotic risk is very low, but there is no need for routine monitoring of thrombotic risk. But in certain clinical settings where you combine therapies, so I think vigilance is needed here. And among like your transition plans, I think a good plan for treating and managing breakthrough bleeds is key. So you should have a clear protocol here. And when a bleed occurs, you don't change something like with emicizumab that we use in clinical practice. You don't change the dose or the interval here. Instead, in patients without inhibitors, you treat with coagulation factor concentrates. Usually for severe bleeds, you use the same dose that we use usually. For moderate bleeds, maybe a reduced dose here. And what is also very important is to recognizing really signs of bleeding, of breakthrough bleedings. This is something we have to learn and discuss to patients to really learn, understand early signs of bleeding and also when to seek medical intervention. And likewise, also for patients with inhibitors, you need a clear plan for managing breakthrough bleeds. Here, of course, you treat breakthrough bleeds with bypassing agents. The agent that is recommended is the recombinant factor VIIa product at the dosages that we know for treating bleeds. There has been in the past a warning for using APCC, but I think there is also now some more information that you could use APCC, but limit the dose here. So there is a dose limit. You should not exceed the dose limit here. And overall, I think as we are here, education is important and training is important. Because we need to educate ourselves, but we also have to educate the clinical staff. So to understand mechanisms of action, the route of administration, how to monitor them. Of course, likewise, it's important to train patients and caregivers on subcutaneous administration for home treatments. And this is something where I also spend a lot of time to patients. So this is completely different, and they need to be trained, and this is something I pay a lot of attention to, because it will help patients and help you that patients are adhering to therapies here. And then some instruction to patients on lab values, because patients will be surprised when they get their lab results and with the usual APTT, one-stage clotting assays, and they have 300% here. So you have to instruct them what this means here. And again, we come back here, how to manage the bleeding is also relevant. And also with this novel therapies, we should follow patients. So long-term follow-up is important. So this you should continue with your regular visits here, and especially monitor potential late onset adverse events as the population of people with hemophilia is aging. And I'm representing the adult population here today. And likewise, it's important because the type of monitoring is changing here. So we expect that there is a good bleed control, and there should be a focus on assessing joint health here. I think this is the focus of clinical monitoring in the future. And we need data after more marketing of this drug. So this was the case for emicizumab, but it will be also the case for the novel factor VIII mimetics. And whenever possible, so I would really advocate to participate in post-marketing surveillance programs to contribute to data generation outside of the clinical trial setting, especially with the novel agents. So I will hand over to you, Cedric, so to learn a little bit more, what is the evidence on like efficacy and safety of the first generation of the factor VIII mimetic that we are using?
Well, thank you. So we'll start with emicizumab, but then you will follow with the other products and more recent data. But it's clear that we have learned a lot about emicizumab, and emicizumab has been, as you all know, extensively validated in this trial program, AVEN, AVEN 1, 2, 3, 4. I'll come back to that. And as you can see on the slide, with different types of population. And more recently, the AVEN 7 study, very important one in my view, that studied if this agent could be started very early in life, because clearly this is the intention, prevent joint damage as early as possible. So this is a busy slide, but showing you the different population. And I think it made sense to have different trials, because this is an heterogeneous population. And as you can see, AVEN 1, and this was expected, and that made sense, had to focus on these patients who have an inhibitor, because clearly emicizumab was first validated in patients who have antibodies against factor VIII, and clearly these factor VIII mimetics do offer a unique opportunity to bypass factor VIII much more easily than the classical bypassing agents that such as 7A and APCC. So that was AVEN 1. AVEN 2 focused more on the pediatric population. AVEN 3 included patients without inhibitors, and AVEN 4 focused on a less frequent treatment regimen. Emicizumab was given every 4 weeks. So honestly, we don't have time to go into the details, but what we know is that clearly that drug is effective in terms of bleed control. So this is a pooled analysis of this AVEN 1 to 4 study, clearly showing you don't need to be a skilled statistician to see that the ABR is low, and that the ABR, as we see in clinical trials, we know that the less you bleed, the less you will bleed, and clearly the ABR does decrease with time. And this is not an effect related to inclusion in clinical trial. If we also pay attention to more recent data in the real life, they are even better. And if you consider the patients who achieve zero bleed, so this is a parameter that we increasingly look at. Well, as you can see in dark blue, the proportion of patients having zero bleed is quite high, and also does improve with time. So very good results. And these are patients with and without inhibitor. Well, it's clear that we need to be cautious. If APCC does contain a lot of factor 9 and a lot of factor 10. So it's clear that if you mix emicizumab with APCC, emicizumab will be so happy to meet so much factor 9 and 10. So it's clear that this will give thrombosis if you give high dose for a prolonged period of time. So, and I am aware that in some parts of the world, they never associated the two drugs because they anticipated this kind of complication that, in my view, should have been anticipated from the beginning. So clearly, don't do that. Although, as you already mentioned, APCC can still be used, but very cautiously, low dose for a short period. There are other side effects, injection site reactions, as you can see in the box. Yes, that does happen in some patients. And the other one is the development of anti-drug antibodies, what we call ADA, but this is quite infrequent. So as you can see here on the slide, 5.1%, and I think if you look at the most recent data, this is quite low. But you need to pay attention to that. That could still happen. In my own experience, I haven't seen ADA. I know if you've seen ADA yourself, but this is something that we should be aware of. Clearly, and Cihan, you already emphasized this. So this bispecific antibody works differently from factor VIII. So it will impact on the blood test. And the blood test that we most frequently use is the APTT or different tests that are derived from the APTT, and they will all be corrected, spuriously corrected. So it's clear that if your patient is on emicizumab, his APTT is short. If the APTT is not short, so either the patient is not taking it, or he has developed an ADA, which is quite infrequent. So this is something we need to pay attention to. The patient should understand a little bit about this, but we certainly need to inform our colleagues that, when they have to admit one of our patients in the accident emergency room on a Saturday evening, APTT, normal APTT does not mean that the patient is fully protected. So, because as you all know with emicizumab, if you're on emicizumab, yes, you get a partial corrections, you are in a mild range, but you are still a patient with hemophilia. So this is something we need to take into account. So a lot of information here, education is needed to make sure that we do not expose our patients to risk of bleeding. And then, yes, it's a great drug, but you cannot abolish all the bleeds with emicizumab. So patients could still bleed, and if breakthrough bleeds take place, well, how can you manage them? If these patients have an inhibitor, you can use certainly bypassing agents, 7A certainly. But if your patient has a history of inhibitor, maybe the inhibitor has gone away with time. So I think it's important to keep measuring this inhibitor in patients who have not been exposed to factor VIII, because factor VIII could possibly be used again. They will probably be maybe the inhibitor will come back, but you could use it. This is important. And clearly, if the patients do bleed, well, the patients will need factor VIII, will need NOVO7 if they have an inhibitor. This is clear. If the patients do bleed on emicizumab, yes, we need to make sure that the patients are adherent. This is important. We shouldn't overestimate their adherence. There are some patients who sometimes forget about this, or ADA, but the anti-drug antibodies are quite unusual. So measure the APTT. If the APTT is short, that means that the patient is still taking his emicizumab. But we know the blood coagulation is complex and there might be failure somewhere else in the process. So maybe, and I have some patients like that. They do not always respond that well. The majority of the patients do, but the good news is that we will have plenty of other treatments. We will have other bispecific antibodies. We have new versions of factor VIII. We have rebalancing agents. So clearly, we can certainly offer our patients treatment options that could control their bleeding phenotype, if not perfectly controlled with emicizumab. And in terms of surgery, well, clearly, these patients, at least on emicizumab, and we will see with the new bispecific, well, they can certainly undergo many type of minor surgery, minor invasive procedure. In my view, with a little bit of tranexamic acid. Sometimes you need supplementation. So as you beautifully said, it's not a monotherapy. It's not a monotherapy. You still need factor VIII in some situation. And for some minor procedure, you could decide that factor VIII supplementation is needed. But I think that has to be done at an individual level. For major surgery, well, this is the experience collected in the trial, but in the real world, there is much more than that. So here they reported 18 surgery, 15 were managed with prophylactic factor VIII concentrate, as you would expect, and a minority without, and that could result in bleeding complications. This is clear. So let's now move to another agent, a more recent one, and you'll try to summarize what we currently know about Mim8.
Yes, thank you so much, Cedric. So let's move to the next generation factor VIIIa mimetics, and here Mim8. What do we know so far? Of course, I can't introduce you the complete study portfolio of the following drugs, but let's have a taste. So focusing on the Frontier 2 study and the treatment arm where patients were switched from clotting factor prophylaxis, non-severe, so moderately severe and severe hemophilia A patients, and they were randomized to be treated with a once weekly versus a once monthly prophylactic dose with Mim8, and you can see that here the dosing regimen is different to that from emicizumab. So we have a so-called tiered dosing. Patients are receiving according to weight categories and dosing schedule, a loading dose followed by a maintenance dose. And usually a pen device is offered here for these patients. Mim8 is also currently being investigated in patients who are switching from emicizumab to Mim8. I think this is a very important study because I think that in the future, patients might really switch from one mimetic or one non-factor therapy to the other, and we need more information. Of course, the primary objectives were to demonstrate non-inferiority of bleeding episodes with the once weekly and once monthly Mim8 versus clotting factor concentrate, followed by a confirmatory superiority test in the same sequence if non-inferiority is demonstrated. Of course, the primary endpoints are to evaluate the breakthrough bleeding episodes, and of course secondary endpoints include the number of subgroups of breakthrough bleeds, spontaneous, joint, traumatic and target joint bleeds. Mim8 plasma concentration was observed, consumption of factor product per treatment treat, the number of injection site reactions. We always talk about injection site. We talk about the benefits of subcutaneous administration, but we also have to take into account that this might be associated with uncomfortability, with pain, particularly in children. This has been reported with emicizumab, and of course we are going to look for immunogenicity, the occurrence of anti-Mim8 antibodies. And what we can see until now, and let's focus on outcome of bleeds, that about 2/3 of the patients being treated either weekly or monthly were bleed-free, leading to a median ABR of 0. So that's why we are now more focused on mean ABR, what you can see in this figure, and mean ABR was once more reduced with the either once weekly or once monthly application of Mim8 compared to the previous clotting factor prophylaxis group. And on the right side of this slide, you can really see that compared to the previous clotting factor therapy, there are advantages for the different subgroups of bleeds with the use of Mim8. Looking for safety, and I want to shorten this, I think the most important or the AE of special interest is the occurrence of thromboembolic events, and in both arms, the weekly as well as the monthly treatment arm, no thromboembolic events could be observed. There were 2 patients who discontinued with the product. However, this was one patient with coronary artery disease, which was unlikely to be associated with this drug, and one patient with a sleeping disorder and dyspepsia. If we could look at the injection site reactions, we can say that in both arms, the ones weekly as well the ones monthly treatment arms, they were very low, around 10%. So no safety concerns were observed in patients treated with Mim8. And this could also shown in the FVIIIa studies where patients were switched from emicizumab to Mim8. The switch was well tolerated over 26 weeks in 68 patients with mostly mild, moderate tears, no thromboembolic events, hypersensitivity or discontinuations occurred. Focusing on NXT007. So here we have preclinical data, and you can see here the first figure, green curve, shows you the peak thrombin generation with the use of emicizumab. And if you look at the blue curve, you can see that there is significantly more thrombin generated with this new agent NXT007 in mice. And you can also see that the bleeding time could be shortened. There were no in vivo prothrombotic effects at therapeutic as well as supratherapeutic concentrations with this agent. Now, there is a study conducted in healthy volunteers, 40 in total, which were assigned to different dosing cohorts and who received a single dose of NXT007. The most important thing was that the administration at different doses was safe. 30% developed anti-drug antibodies. However, this was a dose-dependent effect and did not impact safety. And you can see on this curve that an APTT shortening was observed with increasing doses of NXT007. Also an increased thrombin generation, this is not shown here on this slide, could be observed. And newest data showed that in the trial with hemophilia patients, NXT007 led to decrease in ABR compared to baseline in hemophilia A, with no safety concerns up to the highest dose cohort. This is precisely this study where these information was gained. It is a phase 1-2 open label study which includes severe to moderate hemophilia A patients with all ages. In the part 1, multiple ascending doses have been administered to adult and adolescent participants, and in the second part of the study, pediatric patients will be included. So the objective of this study was to investigate the safety. This was the primary endpoint, and tolerability, of course. And secondary endpoints included pharmacokinetic and pharmacodynamic investigations, as well as immunogenicity, so the number of patients who develop anti-drug antibodies, and of course ABR for treated spontaneous bleeds and treated joint bleed, as shown with the preliminary results. What about efficacy and safety of INNO8? This is the youngest child. So information is still restricted on preclinical studies. Here studies in beagle dogs, and you can see that INNO8 had a 115-hour terminal half-life in those dogs based on intravenous dosing study. You can see here the yellow and the red lines showing that this could be achieved with different doses. And on the blue, on the next figure, you can see that repeated daily oral dosing, because this is the intention of this drug, to be administered orally, reduce the exposure variability in beagle dogs and led to the referring concentrations here in those patients. Of course, there is a program planned called Voyager, a phase 1 study of INNO8, where healthy men, adult men, will be randomized according to be treated with ascending doses intravenously and ascending doses orally. And the objective of this study is to investigate, of course, safety, tolerability, pharmacokinetics, and pharmacodynamics. And with that, I think I have to generate you or to cause some appetite about these new mimetics. Nevertheless, we would really like to know what is the real world evidence for factor VIII mimetics, and which will be the future directions. Cihan, this is your task now.
Absolutely. So let's go back to the real world evidence and maybe discuss some really frequent questions in the clinical practice today. First, and I think maybe one of the most frequently discussed questions, and I have seen fights on conferences on pro and con sessions, is in patients with inhibitors, should factor VIII mimetic be used instead of immune tolerance induction, ITI therapy here? And I'm glad that we have some pediatricians today here in the audience, and I hope they will submit then their question and participate in the discussion. But guidelines like the World Federation of Haemophilia guidelines, they recommend in patients with hemophilia A with persistent inhibitors, or where ITI has failed, or where never ITI was performed, emicizumab prophylaxis should be used over bypassing agent prophylaxis. And I think we will discuss this in more detail. There are some protocols for pediatric patients, so guiding how to combine ITI and factor VIII concentrates, especially where emicizumab is used as a prophylaxis to prevent bleeding while ITI is performed. And there is one prospective study, the Motivate study, an observational study, which aims to assess the efficacy and safety of different approaches and strategies here, where Carmen is deeply involved, and we can direct our question to Carmen when it comes to this study. But here it's the strategy of ITI without emicizumab, or ITI with emicizumab, or emicizumab alone without ITI. And I think this will be a very interesting question. And so what is the current clinical practice here? We have some information from single centers here, for instance, one here from Israel here, about what is the caregivers and patients' attitude towards ITI. And we have information from this smaller study that probably ITI might be delayed or avoided when emicizumab prophylaxis is used. And here in this study, parents were also asked, and the parents' preference was to defer or even to avoid ITI here, and parents also preferred emicizumab prophylaxis alone. And especially if you look at patient characteristics where emicizumab prophylaxis alone was preferred, these patients were the younger patients here. Of course, I can imagine the reasons here why this is the case, because regular intravenous factor replacement for ITI is probably very challenging, especially in very younger patients. And this study also analyzed the impact of emicizumab on inhibitor titers in those who've previously failed ITI, in those with successful ITI, and in those where ITI was never performed. Here, and you can see there is not much really influence on the inhibitor titers over time. Probably there is in those who were never ITI was performed, the more decrease, but also in those with failed ITI, there is also a decrease here. And over time, sometimes inhibitor might also disappear here. I don't know what the chance is of a spontaneous disappearance of the inhibitor here, but we will see. And I mean, bleeds are well controlled with the factor VIII mimetics, and we know this from emicizumab here. And the question is here, what impact do factor VIII mimetics like emicizumab have on quality of life? And we have here some data from the clinical trial program of emicizumab presented by Cedric here in the Haven 2 study, so in the pediatric population. So there is a significant improvement of quality of life very early, and especially in specific domains like sports and school and physical health here. And this is in line with like caregivers impression here, but also we see in the adult population in even 3 and 4 improvements of quality of life. So the scores are decreasing, which is good, but the improvements in the adult population are observed much later than in the pediatric population here, and it's still the physical health that is going to improve here. And the improvements are maintained, and one domain where you see a quick improvement is pain. And this is with every optimization of therapy, we see a quick response in the pain domain. Pain is decreasing here. So, and what can we expect from the next generation of factor VIII therapies and mimetics? Of course, we had heard some first results, but we expect, of course, enhanced bleeding protection, because the next generation of factor VIII therapies, as we have learned, they are more potent. They provide a sustained factor VIII mimetic activity more than the current first generation. The first data that we have indicate a lower ABR, but we will see and wait for the total report of the trials that are ongoing or for the future trials that are performed. And then dosing and administration is a little bit different, and you already referred to. First of all, there is, like with the new factor VIII mimetics, especially with Mim8, there will be a self-injectable pen. So I think I found it amazing. So if you have seen this pen, it's really cool, something very cool. And with InnoAid, a completely new rule of administration, oral route. So, I mean, we always have dreamed of having an oral drug. That would be a huge progress here. Of course, then there is the question of dosing intervals. Can we extend them, or can we adjust them here? But still, I think with these novel drugs, they have, according to the first data that we have from the phase 3 trial of Mim8, or the first phase 1 and 2 trials of NXT007, they have an acceptable safety, but still we have to observe their long-term effects. Especially one point is discussed a lot. This is the risk of thrombosis here, and this remains to be studied further. And some people, and there is a lot of enthusiasm in the hemophilia community here. And I think we all have our really positive experiences when we use this factor VIII mimetics here. But some colleagues here even say that this is a game changer, especially the first generation of factor VIII mimetics that we are using. And this is, I think, true. It changed our treatment practice a lot, and especially, and we expect that people around the world, especially patients from low-income country, might benefit from these new therapies here. And there are also colleagues like Cedric, among us today. They also advocate that these new therapies, that these new therapies should be put on the list of essential medicines of the World Federation of World Health Organization. So this is a long list, and I agree, because more and more people are using these therapies here, and they deserve to be put on this therapy because they are effective and they are safe here. And I will continue. So this was the slide here, but anyway. And then one of Cedric's arguments is that especially in regions where we have not access to treatments, in low-income countries, the benefit, or the people will benefit, and it will contribute to health equity in low-income countries. And this is indeed the case. And you and Katrin have published this very nice paper which illustrates what really the potential of this new treatments is in low-income countries. A prospective study were performed in the Ivory Coast. 33 boys aged between 2 and 13 with severe hemophilia A initiated prophylaxis with emicizumab, and 99% reduction in bleeding rate was observed at 12 months, and the number of zero bleeds has increased dramatically here. So we have learned a lot in this comprehensive symposium here, and what are the key takeaways from this symposium here? The factor mimetics have very special properties that will overcome limitation of the factor VIII replacement therapies, reducing bleeding in hemophilia patients, and especially including those with inhibitors. And I would like again to remind you that factor VIII mimetics will not be a monotherapies. You might need combination with therapies in certain settings like breakthrough bleeds or the surgeries. And they have favorable safety profiles, but we need still to long-term data and observe them. And clinical monitoring is I think, quite important for these therapies here. So we will now go to the panel discussion. So I would like to start with one question, Cedric. So you said with previous treatments, so it was not possible to receive 100% prophylaxis rate, and how does it change in your center or in your country with the availability of this first generation of factor VIII mimetic?
Well, I think that was the first achievement of that product. Honestly, we had many patients who could not strictly adhere, to a IV treatment regimen with 1, 2, 3 infusions per week IV. They couldn't do it. So clearly having an agent that you give subcut completely changed their life. And also, it gives a steady protection over time. So I think that was in my hospital, in my practice, in our center, a major achievement is, and let's not forget that having a patient with hemophilia on prophylaxis, this is the main goal, the main ambition, the main objective that we need to achieve. And this is possible today. It was not. We know we do we do not cure this patient. They still have factor VIII deficiency, but, instead of having low levels, they have at least equivalent 10, 15, 20, even more. So I think that completely changed the management of our patients.
Absolutely. This is also my feeling here, that we have increased the rate of prophylaxis in our. Yeah.
Without age limitation,
Yeah.
from birth to death. So, and I don't see why, this is something we had some very old patient who could never be on prophylaxis, and now they're on prophylaxis. Even, they could be 80, 85. We do not hesitate to start them on prophylaxis. They should all be on prophylaxis.
I like the first question here. So, we cannot really, we don't have a laboratory parameter to reflect the hemostatic capacity here. And especially, we would love to have like a number which tells us the factor VIII equivalency of the non-factor therapies. So what are your thoughts here about like the discussion of factor VIII equivalencies?
So this is really a very difficult issue, because on the one side, we would like to know this equivalence, but also patients would like to know where are they, because we are all living extremely with factor VIII activities. So I think this is very difficult to define, and I think that there are individual differences. So there is not one potential factor VIII equivalence in for all patients. What I think what we have to admit is that we are changing patients from severe to moderate hemophilia to a very mild hemophilia. We do not completely normalize hemostasis, and with that, it becomes clear that patients might need additional treatment in certain situations when they have a relevant bleed or when they undergo surgery, particularly major surgery. So these are my thoughts. The way to measure factor VIII equivalence using thrombin generation is highly discussed, and
And
it's very difficult.
At least I think the results are very variable. So thrombin generation is not standardized. So because it's measured through thrombin generation to compare the equivalency. But Cedric, we always love to compare therapies in treatments with each other. And one of the question is the benefit of MIT8 over Hemlibra. Can we say something? Is it like the pen, or do you think it will be something else? The efficacy, it's difficult to answer, but
Well, I think it will. Well, yes, clearly the pen will be perceived as a major advantage. The fact that it is given, every month, yes, but we will see, whether there is a clear difference in the bleeding control. So this is also what we need to see in the future. So, but no, I think it's quite important. We don't like monopoly in this, in our field, in our community. So having more products, more competition, I think this is always good, and more opportunity for our patients. So clearly we are now entering a new era of therapeutic approach with these bispecific antibodies. And as we had for factor VIII, we had several generations of factor VIII, and now I think we are entering a phase where era where we have different generations of bispecific, and I think still, there is a lot to do here.
Absolutely. I think this is also a very difficult question to answer and compare efficacy indirectly. So we do not have head-to-head studies here comparing two studies, two drugs, or with each other. But maybe this will come in the future. This is the question of phase III.
Yes,
designed.
It will be very difficult to conduct such a study. If we look at the endpoints, the traditional endpoints are breakthrough bleeds, and they occur very, very rarely. So at the very end, in order to prove a difference concerning bleeding rate, we need huge cohorts, and we have to observe the patients for a longer period. I think for the long run, our aim should be, of course, to prevent bleeds, but to achieve the complete prevention of hemophilic arthropathy. I think this should be our aim. However, this can be investigated. This can only be investigated in very small children, and we need time in order to explore this. But maybe we can include more examinations which are focused on joint health, such as ultrasound, detecting quite early synovitis. I think we have the tools, but they have to be implemented into these
And it
studies.
would be, I think, a challenge to implement the endpoints in clinical study. And I would like to thank both of you. It was a great pleasure with you together having this symposium. I would also like to thank Novo Nordisk and Roche for providing an educational grant to support this program here. I would like you, the audience who has participated, and I wish you a wonderful rest of the conference.